Today we will be discussing about one of the important concept in ICU care settings, that is nothing but weaning sequence. So how to wean a patient from mechanical ventilation. So here we might think actually intubation and maintaining the patient on ventilator is more important, whereas weaning is an easy process, but removing the patient from ventilator is equally important because it might lead to untoward consequences. That's why we will discuss it today. Just follow through this lecture so that you will get to know what you were doing was actually right and where you can improvise. So mainly when it comes to weaning, first we have to check whether the individual is ready to wean or not. So we have to check that. Then once we feel the individual is ready, we will give something called as spontaneous breathing trial that we will be discussing. And once the patient has undergone that trial, we will assess whether he or she has tolerated that trial or not. Suppose the individual tolerates it well, then there will be some final checklist which we will be doing before moving ahead with weaning process. So all these components we will be discussing. First of all, we know that mechanical ventilation is a very useful life-saving tool, but it has some complications, like there will be chances of infections and there will be chances of airway trauma. So the rationale and goal should be to proceed with withdrawal as quickly as possible if the patient is tolerating. So this is the intention and goal of weaning. And weaning process is nothing but gradual withdrawal of the mechanical ventilation. It has two components actually. One is called as liberation, one more is extubation. Liberation in the sense, suppose the patient is on mechanical ventilation, if we remove ventilation completely so that the patient will no more require any form of mechanical ventilation support, that is called as liberation. So that will lead to freedom or autonomous breathing. Whereas extubation or decannulation is whatever the endotracheal tube we had inserted, that we will be removing out. Or suppose the patient has tracheostomy tube, we will be decannulating it. But this individual probably will be requiring some or the other form of mechanical ventilation even after removing of that particular instrument. So that is nothing but extubation. Hope you got the clear difference between these two terminologies. Then once we plan for weaning, we have to check for few of the parameters. For example, whether the disease for which we had intubated the individual has resolved completely or whether it is resolving or not. For example, most commonly in respiratory failures, pneumonia, acute exacerbation of COPD or asthma, we will be utilizing mechanical ventilation. We might have intubated the individual. So based on the clinical assessment, chest auscultation, even we can take the help of imaging, we will be assessing whether the underlying process has resolved or not. If it has resolved or improved, or if there is quite better improvement, then we can plan for weaning. This is the first important checkpoint. Then we have to look for patient's readiness, in the sense patient should be awake, cooperative, in the sense they should be able to follow simple commands, that we have to assess. Then hemodynamically stable, we have to check for vitals and look for this, and there should be cough reflex present and the individual should be able to protect their airway. So we have to ask the individual to cough. If they are able to do so, then they will be protecting their airways. Third thing is the patient should be on minimal ventilatory settings and minimal vasopressor therapy. For example, we should be gradually tapering few of the numericals, like the patient should reach PEEP of less than 8 cm of water, and FiO2 we all start from 100%. Gradually we have to taper it, and once it is less than 50%, then we can consider that individual for weaning. This is related to ventilatory setting. What about vasopressors? Ideally, the patient should not be requiring any form of vasopressors, or there should be very minimal vasopressor requirement which should be able to maintain the hemodynamic parameters as stable. So these numericals we have to remember. Then before considering SBT, we have to check for SAT, that is spontaneous awakening trials. Usually patients will be sedated or given some neuromuscular relaxants. So every day without fail we have to keep the patient off sedation to look for spontaneous awakening. So reduce the sedatives or stop it. assess the mental status of the individual. They should not be irritable or agitated. They should be calm and cooperative and should be able to follow some simple commands. So in that case, we can consider spontaneous awakening trial is successful and we can go ahead with SBT. Now comes the actual process of SBT. So what we will do here, how will be the trial? We will utilize different methods. For example, we can change the ventilator mode to pressure support ventilation. In that, the pressure support should be 5 to 10 centimeter of water with PEEP of 5 centimeter of water. Otherwise, we can choose CPAP mode, providing 5 centimeter of water. That much amount of pressure should be provided. Otherwise, we can choose with T-tube or T-piece trial, what we can say. So, all these things should be done for 30 to 60 minutes. And the head end of the bed should be elevated by 30 to 60 degree. So, we will keep that patient in that particular angle and we will be changing the ventilator settings to either pressure support mode or CPAP, or otherwise we can utilize T-piece. On these supports, we will be observing the patient for 30 to 60 minutes. Then we will be evaluating few of the parameters to look for whether the individual has tolerated the trial or not. So how to assess whether the individual is tolerating or not? There are some 6 parameters we have to assess before and after. For example, there is something called as rapid shallow breathing index. So this should be less than 105 number. This index is calculated using 2 parameters. One is respiratory rate divided by tidal volume. For example, I will give 2 scenarios. After the 30 to 60 minutes of SBT trial, one individual has the respiratory rate of 12 and the tidal volume of 500, that is 0.5 liters. So here this index will be how much? So it will be 24. Another individual, for example, is having respiratory rate of about 40 breaths per minute or cycles per minute with tidal volume of about 0.25. So here the ratio will be, it will come to 160. So the cutoff point is 105. So this individual we can consider has tolerated the trial nicely, and the second individual is not tolerating the spontaneous breath trial. So that particular individual requires ventilatory support for quite a longer time. This is the assessment. So as you can see, here we have mentioned the normal numericals. So this individual is almost normalized, whereas this respiratory rate of about 40 with lower minute ventilation or tidal volume, obviously this will indicate this individual has not yet improved well. So this is about the rapid shallow breathing index. Then we have to look for some of the parameters like saturation should be more than 90% and ABG should show oxygenation of more than 60, pH should be more than 7.32, and whenever we repeat the ABG before and after the trial, there should not be any increase in PaCO2 by 10 mmHg from the start of trial. So these are related to ABG we can consider. Then when we assess respiratory rate, it should be less than 30 or 35 breaths per minute, and change in the respiratory rate should be less than 50%, no much changes. When we assess hemodynamic parameters, heart rate should be maintained below 120 to 140 beats per minute, and suppose the heart rate increases with trial, it should not be more than 20%, and BP should be maintained between 90 and 180 systolic blood pressure, and any changes should not be more than 20% again. Coming to mental status assessment, there should not be any significant change in the mental status. For example, there should be no evidence of anxiety or agitation, and work of breathing and physical signs, there should not be any diaphoresis or increased work of breathing. So these parameters should be assessed by the end of trial. So if all these parameters are looking fine, then we can say this individual has tolerated the trial well. So always check these 6 points at the end of trial. Once the patient appears to be tolerating SBT, then the final test will be related to cuff leak test. So before extubation, perform this one. It is nothing but what we have to do. We have to measure the tidal volume which is appearing on the ventilator monitor. So just record that initial tidal volume. For example, if we consider 500 ml, we have to deflate the cuff. After deflating, wait for some stable breaths to come out, then remeasure the tidal volume after deflation. So for example, if it is 380 ml, then we have to look for the differences between these two. The change should be more than 110. That will indicate there is cuff leakage. So it should be there. Cuff leak test should be positive. That is, cuff leak should be present so that we can proceed with the extubation. Suppose the change is not much. For example, initially it was 500 and even after deflation, if it is some 450, so the change will be hardly 50 ml. This will indicate what? Even after the deflation of the cuff, there is something which is obstructing. That is nothing but probability of laryngeal edema. So in that case, we have to consider the individual as having high risk of laryngeal edema post extubation. So we should not proceed with the extubation in that case, even if the individual has tolerated SBT trial. So in that case, we can utilize steroid nebulization and all so that the laryngeal edema will come down. This test we have to remember without fail. Okay, now cuff leak test is also positive. Then we will proceed with the extubation. Once extubated, what should be the next steps? We should ask the individual to cough frequently within first few minutes so that there will be clearance of secretions if anything is present in the airway. Then always monitor the individual in ICU for a short period of time so that there might not be any chances of reintubation again. Then some individuals will require transition to other forms of support. For example, NIV or humidified high flow nasal cannula oxygen supply, or some will be tolerated better with just supplemental oxygen. So these things we have to take care of. Then comes one more situation where you have given SBT trial but the individual is not tolerating much. As we have discussed, those 6 parameters you are assessing before and at the end of SBT trial. So you might observe the patient is having more work of breathing, hemodynamic parameters are becoming unstable, or they are becoming diaphoretic, agitated, all these things. That will suggest the individual is not tolerating SBT. So what might be the reason? So always look for the factors if you are facing difficulty in weaning the patient. So for this, we can utilize one acronym called as Weans Now. So according to the letters, remember few points when you face difficulty in weaning an individual from mechanical ventilation. W stands for wakefulness. We have to avoid over sedation and try to wean in the morning hours where patient will be most awake. E stands for endotracheal tube related things. For example, consider supplemental pressure support ventilation during trial, because if you give T-piece trial, some individuals might not tolerate it because of the resistance offered by ET tube. So for them, we have to give counter resistance in the form of pressure support. So utilize PSV or CPAP mode. Then we have to obviously suction the secretions, and when we get ABG, if any acidosis or alkalosis is there, try to correct it, treat it. And coming to nutrition, ensure adequate nutritional support, and any electrolyte deficiencies, imbalances, we have to correct them. S stands for secretions. So we have to clear the secretions regularly and avoid excessive dehydration. Coming to N, it stands for neuromuscular factors. So avoid neuromuscular depressing medications like neuromuscular blockers, and also avoid unnecessary corticosteroids. O stands for obstruction of airways. So in that case, we can utilize bronchodilators if required and exclude any foreign bodies within the airways. Finally, W stands for a wider clinical context. In the sense, all these above parameters should be checked when we face difficulty in weaning a patient from ventilator. So remember, Weans Now checklist should be assessed. So this was about the section on weaning from mechanical ventilation. Hope the things are clearer now and you have assessed yourself whether you are following the proper techniques, proper assessment or not. If any changes required in your practice, you can adopt it after this video. So overall, weaning process should be considered once the patient is ready. Check for the readiness, then give the trial for 30 to 60 minutes. If the patient is tolerating well, then we have to perform cuff leak test. If the test is positive, go ahead with extubation, then give post-extubation care. Suppose you are facing difficulty in weaning, Check for the factors utilizing acronym WEANS now. This was the overall summary. Hope you find it helpful. Please share it among your friends who are working in ICU setups. We will come up with such informative videos on our channel. So please subscribe and support the channel. Thank you so much.